Hi, how are you? And do you want me to put it up in presenter mode or just in slides? And then she's going to give you the time left, which I think will be just fine.
It's a postprandial yawn.
I think in my head somewhere I don't know I did that. Now I'm like, what is it? I get no kidding.
I get to introduce you.
Oh, I didn't realize that was happening.
Yep, that's happening.
Okay.
And then I guess I'll
You
probably
introduce me to moderate? That seems
Yeah, but I give you a very teeny tiny introduction, and you give
this
like
is Carey.
more.
She doesn't know directions. She made it here. We're done.
I'll give you a little more than that. I won't go into your full history. But I guess I'll probably be stepping out after that because we're going to be standing room only.
They're standing there. It's our safe zone. That's funny. Yeah, that's our peanut gallery.
Yes. Should probably go sit with them. But I'm going to sit with Sheena.
You know what? I'll just stand. We could probably get away with 2 chairs because one person will always be up. I could probably give away one.
I don't know what
really
one
know
chair is
what-
going to do.
Whatever.
No, just to one of them.
No, I don't.
So we're crowded.
I think we may get in trouble with code. Carey, just FYI.
This room
We
is
may
full.
get in trouble with code. So just give a heads up. If they don't come in the next 45 minutes, we may be lucky, but if they see the aisles, they might,
You're
So-
just too popular.
Wow, this is
It's
awesome.
not me,
We're going to
it's
take
them.
pictures of this. So we
Okay.
can, right? Standing room only. Okay.
All right. Go ahead, Amanda, I guess.
All right, we're going to go ahead and get started. I apologize for the crowdedness in here, but I'm not at all surprised that this is a very popular session. I'm going to introduce our next breakout session. This is OB Sepsis, and I'm going to introduce our moderator, and then she'll introduce from there. So moderating today is Dr. Carey Eppes. Officially, she is the Chief of OB at Bentop Hospital and MFM faculty for Baylor College of Medicine, and the chair for Texas AIM faculty for the Texas AIM program. Unofficially, she is a maternal child superhero, and my dear friend, please welcome Carey Eppes.
So we got warning that we're probably not following fire code at this moment. So just as a warning, we might have to adapt midway, but I'm very glad that you are all very interested in sepsis. So I'm going to introduce our next two speakers, both of whom I think I can also say are MFM superheroes. So the first is Mary Catherine Tolcher. My bias is she's one of our new faculty at Bentab and just started this month, and you'll hear why we're so excited about that. So she is an Atlanta native and has specialized both in Minnesota and Texas. She completed her undergraduate and medical school studies in Georgia before moving to Rochester, Minnesota, and the Mayo Clinic for residency. That's also where she got her master's degree in clinical research. She practiced for 4 years as a hospitalist in Mayo, and then she ended up coming to Baylor to do her MFM and critical care fellowship. So she's both a joint MFM and critical care physician. And now she's joined us at Baylor and at Bentab. And then also Emily Adhikari, who is an assistant professor at Parkland at UT Southwestern Medical Center. She did her fellowship there as well, with a focus on infectious disease and affecting pregnant women. She's currently the medical director of the perinatal infectious diseases at Parkland Hospital, and in this role, she supervises pregnancy care for Dallas County women living with HIV, syphilis, and other infectious diseases. She works closely with hospital leadership and the Dallas County Health Department to coordinate surveillance efforts, and she was very involved in things such as Zika, measles, Ebola, various outbreaks, probably now maybe transitioning to coronavirus. Her research efforts focus on optimizing maternal health outcomes in disadvantaged populations. And so I'm really happy to welcome both of our speakers. They're going to talk about a particularly challenging topic, and I think one that we're still struggling with exactly how to most effectively reduce maternal morbidity and mortality for. So I'm also very much looking forward to the discussion that happens after they present. And with that, I will turn it over to our two speakers.
Okay, everybody can hear me okay? All right. Thanks for having me, and thanks for giving this topic a broad audience. I think we all share a collective interest, but it's really important for mothers. So let's talk about obstetric sepsis. I have no financial disclosures, and at the end of this talk, I hope that you'll be able to describe the epidemiology of sepsis in obstetrics, name some barriers to diagnosing and treating sepsis in pregnant and postpartum women, and diagnose or describe strategies for evaluation and management of particular situations and infections in obstetric patients. So this is not Texas data, this is US data. We'll start big. This is the reason we're all here today. Pregnancy-related mortality has been climbing in the United States, and between 1987 and 2016, pregnancy-related mortality ratio rose from 7.2 to 17 pregnancy-related deaths for every 100,000 live births. Now, this is certainly frightening, but it's important to know some key context. The CDC states that the reasons for the overall increase in pregnancy-related mortality are unclear. For potentially because there are changes and differences and potential problems in how we have counted the numerator and denominator over time. For example, there has been improvement in identification of pregnancy-related deaths over time, changes in the way that deaths are coded, but also possible overestimation due to errors in reporting pregnancy status on death certificates. But regardless of past inaccuracies and likely over and under estimation or ascertainment of cases, there's recognition that maternal mortality in the United States is considerably higher than in many other industrialized countries, and that the majority of deaths are preventable. This panel is focused on sepsis, which contributed to 12.5% of pregnancy-related deaths in the US between 2011 and 2016. In Texas, sepsis was a major cause of pregnancy-related deaths in 2011 and 2012 in this data set, particularly among Hispanic women. Here, sepsis is represented by the second bar in each set, and specifically, sepsis was the leading cause of death of pregnancy-related mortality in Hispanic women in this cohort. In 2013, the Texas legislature established the Maternal Mortality and Morbidity Task Force, which began to review cases of pregnancy-related deaths. This is the most recent 2018 task force report required by the Texas legislature. And on review of maternal deaths between 2012 and 2015, the task force found that 32 or 8% of 382 maternal deaths were related to infection and sepsis, with most occurring between 8 and 42 days postpartum. Importantly, the majority of maternal deaths related to infection and sepsis were preventable. A death is considered preventable if the task force finds that there was at least some chance of the death being avoided by one or more reasonable changes in the circumstances of the patient, the provider, facility, systems, or community factors. And with this background, I'll now pass the mic to Dr. Tolcher, who will continue further discussion on identification and management of sepsis in pregnant and postpartum women.
All right, thank you. So we'll move on to the next couple objectives here. I have no disclosures, unfortunately. So sepsis is let's just define it, and I just highlighted the key words here. So sepsis is life-threatening organ dysfunction that's caused by a dysregulated host response to infection. And this definition has changed over the years, but I think the core of what matters has really remained the same, right? So it's an abnormal, exaggerated response to infection. I've converted to a Texan now, 4 years. So you're all familiar with this phrase, but I thought I'd edit this a little bit. Do not mess with sepsis, and I really, truly feel this way. Because I think the key is, like many things, is early and prompt recognition, and not something to be sort of taken lightly or missed or, delayed care. So the good thing about that is recognition is obviously the critical step, and as you'll see here on this slide, the recognition step is very basic. So it's vital signs, and I'll talk a little bit more about more kind of complex scoring systems and things like that. But when we talk about recognizing critically ill patients, it's simple things that we all know about and see every day. Another key component, obviously, is the CBC. And as I go into the algorithm that we're going to sort of recommend that you all use in your practice for screening for sepsis, you'll see that's one early step. Bless you. Are you okay? So there are many scoring systems for identifying early sepsis, and I'm not going to go through all of those in detail, but just want to give sort of a brief overview of those systems and why they're not particularly validated or helpful in our pregnant population. So the first in this orange box here, and this is from the California Maternal Quality Care Collaborative. So a lot of what I'm going to show you is actually from a very recently released sepsis document and sepsis bundle from the California Maternal Quality Care Collaborative. And so this orange box here, they very nicely reviewed some of the scoring systems for screening for sepsis, including SIRS, Muse scores or modified Muse scores, so maternal early warning signs. And then QSOFA is the one at the bottom there. And so without getting into the details of those individual systems, I just wanted to point out that you'll notice that they're all based on vital signs and white blood cell count and basic examination findings like neurological status. And so what you can see here is the sort of sensitivity and specificity of these in pregnancy. And I just, to simplify sensitivity and specificity, so sensitivity is how many sick people can we correctly identify, whereas specificity is how many well people can we correctly identify as well. And so you want each of these numbers to be as close as possible to 1. And so you'll see, just for example here with the QSOFA score, the ability to detect sick people who are actually sick is about 50%, so that's poor. And then, if you look over here for SIRS criteria, for example, the specificity is the worst, meaning that the ability to rule out disease when there is no disease, so identifying well people. And another thing I wanted to point out about these scoring system is that, so these scoring systems all were developed to predict hospital mortality. So I think that's important to point out that they were not developed to detect sepsis, which is the most important thing, right? And another scoring system is the SOS, so sepsis in obstetrics score. And so that was published in the Gray Journal, you can see over here on the right. And again, this number, AUC, is very close to 1, so the test did very well, but for what? Predicting ICU admission. So just to sort of point out that these scoring systems are for identifying women at high risk for ICU admission or death, but they're not really for diagnosing sepsis and that early recognition necessarily. So this is a key because if you're asleep or you want to sleep the rest of the presentation, this is like the one thing that I would suggest that you take with you. So all the scoring systems and all the acronyms and everything, I think California has done us another favor and just released, I think it was like the 23rd, so just a couple days ago, a recommendation for screening for sepsis in pregnancy. So all those things that I told you about besides the SOS were not in pregnant patients. And so I'll just kind of walk through this briefly. So what they did is they broke down the screening process into 2 steps. So the first step is the initial screen. And this is a big flow chart, but I'm going to kind of break it down into sections initially. And so you'll see here that the initial screen is, again, mostly vital signs. So oral temperature that's low or high, heart rate, tachycardia more than 110, respiratory rate more than 24, and then a white blood cell count that's either low or high. And this is a little bit more specific to pregnancy, the numbers, because a white blood cell count is higher in pregnancy, as is the heart rate and can be the respiratory rate, which is why the other scoring systems aren't specific to pregnancy. So if a patient meets any of those 2 criteria, then they've screened positive for possible sepsis. And so this is sort of the next step of the flow chart, step 2, where, okay, now we suspect sepsis. And so the recommendation here in the gray boxes, go ahead and start source-directed antibiotics, start IV fluids, and obviously monitor closely, and then send laboratory studies and do further bedside assessment to actually confirm the diagnosis of sepsis. And in the meanwhile, you'll see kind of in the red circle here along the way that if a patient is hypotensive, meaning their MAP is less than 65, even after a fluid bolus, the recommended bolus of which is 30 milliliters per kilogram, if they remain hypotensive, basically unresponsive to fluid resuscitation, then that is septic shock. Okay, so step 2, and I won't go through all of this, but basically it means that you need to send lab, CBC, coagulation profile, complete metabolic profile, place a Foley catheter, assess the patient's mental status, go ahead and start fluids, go ahead and start antibiotics, because now you suspect infection or sepsis. And then this is the bottom part of the flow chart. The next thing is, okay, so now you've established the diagnosis of sepsis. Sorry, let me go back. So one or more of these criteria in this blue box here were met, and so the patient meets diagnostic criteria for sepsis. So what is the next step? So as I talked about, if they're in shock, then that's why it's red and highlighted, that aggressive therapy is needed. They may need like a rapid response team call, depending on what you have at your institution, consultation with the ICU or admission to the ICU for further assessment may require vasopressors. But if not, Just because a patient isn't septic the moment they present doesn't mean that we don't need to closely monitor them. Here over to the left. And then lactate was one of the diagnostic criteria here in this blue box. So if they do have elevated lactate, one thing to know is that if the patient happens to be in labor or intrapartum, that lactate can be increased just from the process of labor alone. And so they talk about that a little bit more detail in the document. And so they actually sort of tested this algorithm. Remember, I showed you the sensitivity and specificity of the other scoring systems. And in over 14,000 patients, I think it was like 14,700 patients. And you see here the sensitivity was 97% and the specificity 99%. So far, ideally in terms of research, this will be validated in another obstetric population, but I think this is very, very promising that this particular two-step scoring system seems to perform well in our patients. So I got this from the Surviving Sepsis Campaign website. So this is what your patient should look like if they're septic. And this is not a typical patient, and actually this was a male and I put some hair on him, but this is not a drill, right? Don't mess with sepsis. So you'll notice that so I actually like this picture because they broke down kind of the Surviving Sepsis Campaign. There's now a 1-hour bundle. And basically that doesn't mean, okay, the patient comes in, you need to diagnose her, cure her, she's going home, in an hour. But by no means, it just means that all 5 of these things should be started if a patient is in sepsis or septic shock. And so I don't necessarily agree with their order, but I'll just kind of go through. So like we talked about, measuring lactate, because lactate is a marker or surrogate for hypoperfusion. And so it can be followed in terms of when you're administering fluid bowls and resuscitating the patient to measure their response. Obtaining blood cultures, administering antibiotics, giving 30 cc's per kilogram of fluid, and then applying vasopressors if the patient remains hypotensive and unresponsive to fluid, which obviously typically would mean like rapid response or ICU consult. And I just kind of highlighted here that you don't necessarily need to complete all of the 1-hour bundle elements, but they should all kind of be in the works within the first hour. So that's more about screening for sepsis and diagnosing sepsis. So I'll just go through a little bit of management, which the good news is, again, this is all basic and we can all do this. Fluid resuscitation. So I already mentioned the amount, ideally within the first 3 hours with the target blood pressure of a MAP of greater than 65, and assessing kind of fluid responsiveness based on how their blood pressure responds, and also following lactates every 2 to 4 hours. Obtaining blood cultures. However, it's important to note, so blood cultures can actually be sterilized within minutes of receiving antibiotics, depending on what antibiotic. But I think it's important to emphasize that obtaining blood cultures should by no means delay antibiotics. In the previous Surviving Sepsis campaign, they actually said something like 45 minutes, but I think they've moved away from an exact timeline. But that's just still sort of a ballpark, 30, 45 minutes. And then, of course, antibiotics. Empiric, broad spectrum. If there's any, and I'm all about antibiotic stewardship, but if there's any patient that it's justifiable or worthwhile and they come in with sepsis or septic shock, just start big, and you can always kind of narrow later as more information becomes available. So at least 2 antimicrobials are usually aimed at whatever you think based on clinical findings is the most likely source. And so this is, again, just from the Surviving Sepsis campaign. I just wanted to point out a couple of things. So I guess it depends on the individual institution and maybe even the individual provider of, obviously, when do I need to escalate care? But I think probably a general rule for most patients is that if they're not responding to your initial fluid boluses, which for a normal average weight patient is, 2 to 3 liters. Or if they're hypotensive, then consulting an RRT team or an ICU is obviously, but that's something that's really hard to script, and it depends on kind of where you are. Okay, so I was going to run through a case example because that was a really long 2-step algorithm. Do I have time? Okay, so 28-year-old female, obviously, G3P2 at 21 and 6 presents to your OB triage with temperature 101, heart rate 115, and right CVA tenderness. Her blood pressure is 110/70, MAP 83, oxygen saturation is good, 98%, respiratory rate's normal at 20, and she weighs 86 kilograms. There's the big algorithm, but it's okay. So what do you want to do first? I can't hear you. Sounds good. Start IV fluids, right? So start fluid bolus, lactated ringer, normal saline, doesn't matter. Send some labs in order to, I underline the 2 things, right? So she has a fever and she has a heart rate greater than 110. So based on our step 1 initial sepsis screen, she already has 2 of those criteria, right? So action, if suspected infection, we're going to start fluids, increase our monitoring, surveillance, and then move on to further diagnostic evaluation for sepsis. And she's not in shock. Her MAC is 85, so we're okay. And start antibiotics because you know that she has a fever, she's tachycardic, she has right CVA tenderness. We're highly suspicious of infection, so let's just go ahead and order some antibiotics. Okay, you have a really fast lab, and in 30 minutes, you get your lactate back, and it's 2.6, and her blood pressure is 83/50 with a MAP of 61. Okay, somebody say it loud. She's in shock. Yes. So now she's hypotensive. So if you haven't done this stuff before, you're going to do it now, right? So send blood cultures, start antibiotics, call the pharmacy, tell them we need the antibiotics now. Plan on, have it in your mind to sort of repeat your lactate every 2 to 4 hours, assess your resuscitation. You're giving her the fluids that you've already ordered. So if she remains hypotensive, and again, that's why I put she weighs 86 kilograms, after you've given 3 liters of fluid, now what are you going to do? Yes. Call the RRT, maybe they're called something else at other institutions. Call the ICU, consult the ICU, but the patient's in shock and she's not getting better. So this is easy peasy, right? Okay, so I'll turn it back over. This is my pride and joy, Chloe.
Okay, so now let's talk about a couple more specific scenarios of infectious causes of sepsis in obstetric patients. I kind of split it up into antepartum, intrapartum, postpartum, but things can happen at the same time, right? So antepartum, we often see and treat pyelonephritis, influenza, or pneumonia, particularly in the setting of sepsis. We're thinking bacterial sepsis often is a cause. Septic abortion, appendicitis. Intrapartum, one of the most common causes is chorioamnionitis, but that can coincide or be triggered by other things. And postpartum, all of the other causes can happen, right? In addition to endometritis, wound infection or surgical site infection, and mastitis. Importantly, a lot of times a source is not immediately identified. You initiate a workup and management, but you're still trying to find the source of infection. And so it's important to know that the syndrome of sepsis needs to be recognized while you identify the source. So you treat, manage the syndrome of sepsis as you're searching for the source. I'd like to just talk a little bit about the basics, right? So a thorough and a thoughtful history and physical exam are really crucial to identify a suspected source in women with signs of infection or sepsis. So that includes a review of medical comorbidities, surgical and obstetric complications, particularly if a woman shows up postpartum and you did not attend that delivery. The breastfeeding history, outside records may be necessary and relevant, and certainly travel history, right? Nowadays with COVID. A pelvic exam in a pregnant or postpartum woman with signs of infection is a necessary part of the evaluation, right? We cannot forget about that. And then because it's important to explain your findings, you then go over your findings, your assessment to the patient and the family, and give them feedback of what you think the source might be, even if you're not sure, with the caveat or the explanation that things can evolve and change over time. So close the loop on communication with the family, even if you don't have all the answers immediately. Let's go through a few specific infectious diseases. So acute pyelonephritis. That affects 1 to 2% of pregnant women, and it's a leading cause of ICU admission in pregnancy. 80 to 90% of cases happen in the second and third trimester and postpartum. Up to 20% of women will have bacteremia, and common pathogens include E. coli, Klebsiella, Enterobacter, Proteus, and then 10% can be caused by gram-positive organisms. The keys, again, we just covered this, are early intravenous hydration, close monitoring of the patient vital signs, oxygen saturation becomes critical, and broad-spectrum antibiotics. Ampicillin, gentamicin are what we use and are very routinely recommended for their synergistic effect, especially on genitourinary flora. Cefazolin, ceftriaxone are some other alternatives. And then we have a low threshold for renal sonography because if there is an obstructed stone, for example, obstruction with a kidney stone, that is an emergency and that must be relieved as part of the management. Importantly, up to 20% of pregnant women with severe pyelonephritis may have complications like septic shock or acute respiratory distress syndrome, ARDS. Specifically, women who are moderately ill and who then receive their first or second dose of antibiotics may acutely worsen after that initial dose due to a big, massive endotoxin release. That can result in refractory hypotension, and the patient may tank. So then you need to transfer immediately to an ICU setting if your patient is then in septic shock and not responsive to fluids. So care teams need to be aware of that particular aspect of acute pyelonephritis management and be prepared to detect signs of early clinical deterioration so the patient can be transferred to an ICU. Preterm labor can be triggered by this type of endotoxin release and treatment, so monitoring for signs of early labor is really important. And it's flu season, so we're all living this right now, but about 10% of pregnant women will get the flu, and about 10% of those may get superimposed bacterial pneumonia or pneumonitis on top of that. Some of the common etiologies, aside from influenza virus, right? Some common etiologies of superimposed bacterial pneumonia are strep pneumonia, Staph aureus, H flu, mycoplasma pneumonia as well. Importantly, evaluation of pregnant women with influenza-like illness underscores some of the limitations of some of these sepsis scoring systems that we've heard about, especially the old ones, particularly because a woman with uncomplicated viral influenza may look ill, but she may just have viral influenza. But again, I think the point of these early detection systems is that if you don't ask the question, you will never know the answer, right, in terms of the evaluation that's recommended. But again, for uncomplicated viral influenza, supportive care and Tamiflu is recommended regardless of the flu swab. So your flu swab does not give you the answer for clinical management. In a woman who presents with influenza-like illness, you give Tamiflu in flu season. And then you evaluate for superimposed bacterial pneumonia, particularly if she looks ill, has a productive cough, and has abnormal vital signs. Superimposed pneumonia is treated with ceftriaxone or Unison plus azithromycin in addition to Tamiflu. Then septic abortion. So this is diagnosed in endometritis as well. It's diagnosed by clinical exam, and ultrasound can be handy in terms of diagnosing retained products of conception. You have to remove the source, so a DNC may be necessary. Hysterectomy is usually not required, but may be rarely required. Etiologies are often normal vaginal flora. Group A strep is a particularly bad player, and then some Clostridium species. Broad spectrum antibiotics are indicated, particularly with anaerobic coverage, so you need some clindamycin on board. Alternatives, in addition to gentamicin, alternatives are cefoxitin or cefotetin plus doxycycline. And then let's discuss a little bit about chorioamnionitis. This is a weird picture, but I'll explain. We aren't really here to discuss the definition of chorioamnionitis. There's been a lot of discussion about that. But really, it is commonly caused by group B streptococcus, other genitourinary flora, ureaplasma. And when diagnosed or suspected, treatment is broad-spectrum antibiotics that cover GBS specifically. And this becomes important when a woman reports a penicillin allergy, right? ACOG has recently released guidance, a committee opinion, to provide some guidance on this very issue. We use ampicillin and gentamicin in patients diagnosed with chorioamnionitis, and if a woman has a mild penicillin allergy, as shown here in this picture, this is an example of a drug rash to amoxicillin that happens a few days after you take amoxicillin. The antibiotics are cefazolin and gentamicin. It's okay to give a cephalosporin in the majority of cases. For a severe penicillin allergy that's defined by an IgE-mediated hypersensitivity reaction or another life-threatening allergic reaction such as Stevens-Johnson syndrome, then you give clindamycin if the GBS is susceptible or vancomycin plus gentamicin. Importantly, delivery is required for cure. We should all fear situations in which a pre-viable or peri-viable pregnancy or a preterm pregnancy with prolonged ruptured membranes and chorioamnionitis diagnosed are managed conservatively with antibiotics alone, or worse, with no antibiotics when there's no real clear identified source. This risks worsening sepsis, septic shock, and maternal death. Let's be clear in this case about words and definitions. Chorioamnionitis, or intraamniotic infection, is an obstetric indication for delivery. It is also a clinical diagnosis made by an obstetrician. Next, appendicitis. It can be like pyelonephritis in terms of the acuteness of it. If the appendix ruptures in particular, the resulting bacterial peritonitis can really stimulate preterm labor. So early recognition and management is really key. Suspected clinically here, so the diagnosis is made based on the symptoms of pain and nausea and vomiting. And then there can be some imaging involved if the diagnosis is not completely clear. Ultrasound or MRI can be helpful. But again, it's a clinical diagnosis, and then the key is general surgery consultation early on when a diagnosis is suspected, and broad-spectrum antibiotics are started, cefoxitin and flagyl, intravenous hydration, as we talked about, and NPO status. Again, you need to observe for labor because of the risk of that stimulation of from bacterial peritonitis. And next, approximately 3% of postpartum women will develop mastitis, and 10% of those may develop an abscess as a complication. Common causative organisms may be Staph aureus. That may include methicillin-sensitive or resistant organisms, coag-negative staph and viridin streptococci. Management, for mild cases, oral antibiotics can be used. But in this case, we're talking sepsis, right? So we have a very ill patient. She needs intravenous antibiotics. First line can be nafcillin, but if there is a suspicion for MRSA, based on her illness, her clinical status, or a big abscess, then MRSA coverage is indicated with vancomycin. An ultrasound obviously needs to happen for you to diagnose an abscess unless there is obvious fluctuance, and then you have to drain the abscess. Source control is important. For mastitis, continued breast milk expression is actually really important because engorgement on top of mastitis is worse. And then finally, a word about surgical site infections. And this also can apply to women with infected vaginal lacerations. Surgical site infections are more common in women who had a C-section following labor with chorioamnionitis or intraamniotic infection. Common causative organisms include, they're often polymicrobial, but they can include Staph aureus, coag-negative staph, genitourinary species, sometimes Pseudomonas, and streptococci. Group A strep is especially bad and virulent. The treatment, number one, is source control. In cases where, especially when there is a fluid collection, exploration and debridement is important. possibly hysterectomy may be needed. Particularly with end organ infection, if there's gas-forming organisms involved, exploration is urgent. Deep pelvic exploration after recent surgery, now with infection present, can be really tricky. So additional surgical expertise, depending on your institution, may be needed. And then broad-spectrum antibiotics are critical. We use ampicillin, gentamicin, and clindamycin, but for particularly severe cases or sick patients, Zosyn and vancomycin may be the initial agents, and clindamycin if there's suspected necrotizing fasciitis. And then for known or suspected group A strep or Clostridium species, penicillin and clindamycin are critical. So, in conclusion, infection and sepsis in pregnancy are major contributors to maternal morbidity and mortality. Sepsis is an emergency, and early recognition and treatment are key to while identifying the source. And implementing a system-wide response in your organization can improve early detection. A thorough history and physical exam with a pelvic exam are fundamental to identifying a suspected source of infection in pregnant and postpartum women. And that's it. Thank you.
All right, also we have a few minutes for questions. Let me know if you have questions, and if the room can't hear you, we can pass off the microphone. But in the meanwhile, I was going to ask both of you, given that you've done this excellent job portraying that sepsis is a significant cause of morbidity and mortality for pregnant women, and knowing that we all are now trying to have protocols for sepsis, given it being a maternal levels of care requirement, what do you think are critical components for people to have in a protocol, knowing we still have challenges with exact detection? What would you put in there for, or what would you recommend hospitals are putting in there?
Hello? There we go. So in terms of like a comprehensive algorithm, obviously most of my talk was about multiple screening systems and vital signs. So I think something like the MUSE system, maternal early warning system, has worked really well for us at our hospital. So I think that's definitely, in my opinion, is step one. I think other things to consider are potentially order sets, just to make things easy and quick. I did the math for you guys on the, the kilograms and how 30 cc's per kilogram, and Emily reviewed lots of antibiotics and dosages and loading dose, and that stuff gets complicated for sure. So I think making that easy for providers to order quickly is another key component.
I think from my perspective, a lot of reviews of cases that went poorly are due to communication. So I think any system that implements or that has to have policies in place needs to have clear lines of communication for escalation of appropriate care. So notification and communication trees for who to notify in what situations, and then what the expected response will be and the expected time of response. In each system it may be different, but there at least needs to be an outline or an algorithm for whoever happens to be on call at 2 a.m. knows who to call when the situation arises.
What questions do you all have?
One of the confusing things that I seem to run into, we have a good sepsis protocol, but is identifying, if we think a patient she's come in, we've identified she has an infection, but really high suspicion that it's viral, and so I've hesitated in starting antibiotics because I really don't know what to start. And so where do we go from there? I mean, if we think it's flu, of course we're starting Tamiflu, but I don't have any indication that it's pneumonia or, that it's a lower respiratory.
So I'm just going to repeat the question, which we'll answer very quickly. So if you see a patient that you believe is septic and you suspect it's viral, what would you recommend you're initiating for antimicrobial, antiviral therapy? Either of you. Yeah, either of you.
About to answer your
No. I'm moderating. I'm not participating.
I was waiting for your answer. Here's where I think, particularly with viral influenza, we have struggled a lot because we looked at our data over the bad flu season of 2017 to 2018. And our hospital has used the SIRS criteria as a initial trigger. We all know how poorly that may identify sick patients, but again, 25%, a quarter of women who showed up with influenza-like illness would trigger that. And that's a lot of people at Parkland Hospital. So I don't necessarily want to start empiric broad-spectrum antibiotics on a quarter of women with influenza-like illness. I think that's where some of these systems break down. I think they're designed for bacterial pathogens in most cases. So clinical assessment and repeat clinical assessment and repeat clinical assessment are going to be key for these cases. Again, if you needed to cover for a pneumonia in a very ill patient that you need to admit to the hospital, and you do suspect sepsis or something beyond influenza, which I leave open to a clinical assessment. I don't necessarily think every woman with influenza needs broad-spectrum antibiotics, but I think there is something else going on, then I would start an agent that covers bacterial pneumonia. So we talked about ceftriaxone and azithromycin are common agents to use.
I'm going to now, well, I just said I'm moderating, not answering, but now I want to answer. I was just going to say, I see, I agree with what you were saying and not wanting to always throw a million antibiotics at folks. I also think we're more often subject to anchoring bias than the opposite. And so I would say if somebody's septic, starting big and then narrowing is where I would go. Only because you would hate to presume it's one thing and have it be something else and have that become catastrophic. So if a woman is presenting and is septic, which might be different by your criteria, I would go big first.
That's what I was going to say. But I thought, but remind me though, in your question, I thought you had said you suspect a viral infection, but not influenza, is it? Okay, exactly, sorry. Yeah.
It doesn't necessarily look like a patient.
I guess I'm in the middle somewhere, right? Because, as I had said too, your clinical assessment is going to obviously give you clues to, most of the time, not always, except for mystery cases, as to where the infection is. So if you have a high clinical suspicion for influenza, I don't disagree with not starting antibiotics unless, they're a very sick patient and, they meet criteria for sepsis, especially septic shock. So that initial screen, I think a lot of influenza patients would meet that, but sort of the next step where you're looking for organ dysfunction. So, mental status changes, elevated lactate, elevated bilirubin. I mean, I in my clinical experience, I haven't seen that with influenza, so I think that would.
Thank you very much to both of you. If anybody has other further questions, you can come ask them. Otherwise, we're concluding. Thank you, guys.